Welcome to the podcast. I'm your host, Jim Jorgenson, and today I'm joined by pharmacy revenue cycle experts, Maxie Friemel and Tim Miller. Welcome to the show.
Hey, Jim, how's it going?
Thanks, Jim.
Great. Maxie, I first met you a number of years ago when you and Agatha Nolan did a pharmacy revenue cycle workshop at an ASHP meeting. And at the time as a CPO, I thought, I was pretty good at this stuff, but the format looked interesting. So I signed up and wow, turned out there was a lot I didn't know. And it was one of the best workshops I ever did. So I'm really excited to hear about what you and Tim are doing now. So let's start with some introductions and brief bios for people that might not know you. Tell us what you do, how you got there, and let's go Maxie first and then Tim.
Awesome. Thanks, Jim. I actually do remember that year very vividly when you came to the workshop because there was not one, it was a repeat workshop. We did two of them and we had hidden pop quizzes throughout, but I didn't know I needed to change my quiz questions for people who would come and attend it twice. So I do remember that year. And those were some fun years trying to put all of this together and put some method around this madness. A little bit more about me. I graduated from Texas Tech University Health Science Center. I did my residency training at the University of Wisconsin Hospital and Clinics. And that's really where I got my career started as a pharmacy manager in supply chain for the University of Wisconsin. Later life kind of moved me to Denver, Colorado, which I took a role as a pharmacy revenue cycle specialist within SEL Health. And as many jobs descriptions are out there are very vague, this was no different. However, the foresight from the system director of pharmacy and finance had enough foresight at the time and a good working relationship to kind of put a position of this nature together. So I started training with some of the smartest charge master, charge capture analyst, and then they just began to highlight obstacles that they encountered that had to deal with drugs, whether that be invalid NDCs, self-administered drugs, some of the same oldies but goodies that still continue to cause some issues today within the revenue cycle. There was no roadmap. Very few peers were in this role across the U.S. here, so it was a lot of researching, reading, and really having to make decisions in the gray zone. It was no easy feat getting this kind of role started and under my belt. It probably took close to 3 years to finally get just a committee approved. We created a multidisciplinary team, really started focusing and prioritizing concerns. It transitioned, the whole transition in that 3 years was from a state of, we don't know what you're doing or why you're here as a pharmacist. And then by the end of it, as I transitioned out of my role at SEL Health, it was this team had full accountability for anything that touched pharmacy revenue cycle. So it was a complete transition, complete mindset of a transition here. And that took hold within other service lines as well. So it was really treating pharmacy revenue cycle as a true service line. Now I am the senior director with the Visant. I've been with Visant for about 4 years and really enjoy doing just that to multiple organizations, is really trying to bring teams together, pharmacy, revenue cycle, finance, and really trying to create a common language and helping those teams start working together.
Awesome. I can jump in next. Jim, thanks for having me. Really excited to be here today. Looking back kind of over my career, it's really centered around some of the more complex and cost-sensitive areas within the pharmacy landscape. Started out as a clinical pharmacist in the oncology specialty and infusion areas at University of Wisconsin, so also a proud Badger. This was during a time of really rapid growth in things like oral chemotherapy, gene therapy, monoclonals, CAR T, etc. Those treatments were all certainly revolutionary from a clinical standpoint, but they also came with really hefty price tags and some complex billing and reimbursement challenges. So you can imagine that the leaders at our health system became really interested in what I was doing every day and the associated financial impact that we had. Over time, expanded into non-oncology and medical infusion and oversight over our outpatient clinics, where the stakes remain somewhat similar. They were expensive drugs. We were navigating evolving payer requirements and working to strike that balance between clinical care, financial stewardship, and all the regulatory compliance pieces. But doing that all with a patient sort of in front and center throughout the whole process. From there, moved into leadership roles at Freighter Hospital and then later Intermountain Health, where I worked as the revenue practice manager over pharmacy prior to joining the team here at Bisant. And today I'm lucky to be a senior consultant here where I get to support groups across the country and help transform healthcare through pharmacy, specifically optimizing revenue cycle performance for the partners we get to work with. And honestly, the best part, Jim, is when it's done right, it can directly support the best possible patient care, but also ensure the long-term financial sustainability of those groups we get to work with.
Absolutely. Excellent. Thank you. You know, when we talk about pharmacy revenue cycle, I think most people think automatically billing. But, you know, in reality, pharmacy revenue cycle is about a whole lot more than just billing. So to level set a bit here, tell us how you guys think of and approach pharmacy revenue cycle really in total.
I'll take that one, Jim. I really like to start off. HFMA really puts forth a great definition around what is revenue cycle. And I'm going to highlight here because it's all administrative and clinical functions that contribute to the capture and the management and collection of all patient service revenue. So what that really means, it's every process from the patient's initial interaction into a health system or health services to the time their final payment of their account. And so when we say pharmacy revenue cycle, that's what we're talking about. We're talking about all of those processes from start to finish. We just overemphasize drugs and how drugs play a critical role in this and how they become a very complicated role on top of a very already complicated process. So I break it down into really 4 primary phases. We start really focusing where drugs play a big role is really in that pre-access process. You have prior authorizations ongoing, financial counseling that's happening regarding drugs, registration that is vitally important to get everything right on that claim. Almost 80% of the claim is driven by just what's happening in your pre-access process. You have clinical operations where you have nurses, provider documentation, all trying to capture a charge based off of the services that they are actually performing. There's scanning involved, so there's a lot of technology that goes into making this work seamlessly. There's pharmacy technicians, pharmacists capturing the drug waste, etc. You also then think of the mid-cycle, and this is where I think a lot of people go when they say a pharmacy revenue cycle. Oh, it's just the CDM. Well, it's more than just the CDM. There's the medication bill that goes on top of it. There is the CDM, but there is then a whole host of billing, claim, and payer edits that go into play when you're trying to get out a clean claim. And then lastly, we've got a post-access process where you've got follow-up teams and a denial management team. And that's just the high level of what one starts off when they start thinking of pharmacy revenue cycle. And in just those 4 processes, I've already represented 12 different teams. 12 different teams who probably report through different channels, different leaders, and different areas within the organization. So circling back to your question, Jim, yes, it is definitely more than just billing. There is a whole host of people, processes that have to be very bi-directional communication when coming into pharmacy revenue cycle. Tim, do you have any thoughts on that?
Yeah, it's a good call, Maxie. I think you laid out exactly a great framework. It's really about that continuum from beginning to end and making sure that you have processes and people in place to be working in sync to be successful, right? You can't just focus on one area and expect great results. And billing is certainly a crucial component, but it's really just one of that sort of more broad and interconnected process that you described. A lot of organizations are just looking at their gross charges to measure pharmacy performance. Really, you can miss the bigger picture that way. What you're billing doesn't necessarily equate to what you're getting reimbursed and if it's covering the services that you're providing for patients. So you could be potentially leaving dollars on the table due to missed prior authorizations, incorrect medication bill, 340B compliance issues, et cetera. It's really that coordinated effort between pharmacy, rev cycle, IT, compliance, clinical teams. When you get all those groups together, just improve your financial outcomes, but you can also help reduce the administrative burden and provide better care to patients. And ultimately, that's the real goal, right?
Yep, definitely. Given the scope you just described, I think we could probably spend the rest of the day talking about all those elements, but really, since our time's limited, let's focus on some of the most challenging areas. Drug costs are a major financial driver of both expense and revenue. And as more hospitals start to expand or initiate specialty and infusion pharmacy programs, as you noted, Tim, really high cost specialty drugs and biologics can drastically influence both revenue and risk. A single specialty med can cost tens or hundreds of thousands of dollars per patient course. And some of the evolving gene therapies are now pushing that into the millions. And as you described, Maxie, at the front end of these services are prior authorizations, which really can pose a big challenge for organizations. So what are you guys seeing here?
Yeah, this I get an area that I get pretty passionate about is still one of the most complicated process within the whole revenue cycle, and still one of a process that is not standardized. Each clinic could be doing things differently. You might have that is somewhat centralized, and then you have other teams that this process is out there for the clinics to handle on their own. And if you think back of what are we asking to be done here at the pre-access prior authorization process, we are asking sometimes MAs or registration staff. Sometimes, technical folks that have been doing this role for quite some time, but the variety of skill sets that go into this are very vast across the organization. And what we're asking them to do is, hey, you've got an order now. Let's make sure that all clinical documentation is in the chart and meets the medical necessity requirements for a drug. That's one check, right? Then we've got to go down to payer policy still. So the payer policy not only has to be medically necessary, but now it has to be delivered at the right site of care. But I'm only one side of care. So now I have to think through where these patients going to go after they get it one time, or maybe they can't get this drug here at all. Now I've got to determine an alternative product for that patient. And by the way, I need to go tell a provider to change the drug because this drug's not approved. So now we need to get that provider to enter a new drug so we can get this patient approved for a product in our particular location. That's been the challenge for years, right? Now we've got more policies that have been changing some of the coding and the billing guidelines, where we've got more HCPCS codes that are out there, more billing codes for some of the drugs that seemingly were all the same or generically equivalent before. So now we're adding yet another layer of complexity to say, we've got an order for drug X, but we need a bill for drug Y, even though to me it's the same, to a pharmacy team it's the same, but to a payer and to a biller it's different. So that communication process from supply chain now to the provider to when it's dispensed all has to be well coordinated. And so site of care becomes a problem, or we have workflows in place here that say, well, it's easier if you just go across the street because I am financially at risk for everything in my site today, and I can't seem to find a way to get it paid. They're all ending up in denials. So you know what? I just go across the street because it's easier, right? And so we're still seeing a vast number of leakage out of health systems today where it's being shifted to an alternative site of care, maybe because that's where the drug was approved for. Maybe that's part of it. The second part of it is maybe because the administrative burden has become so complicated that it's easier for my patient to go somewhere else than me take the risk internally. So everything is becoming a little bit more complicated. And the one thing I'll layer on top of that is our EMRs today are not keeping up with the technology to keeping up with the pace of change from a policy standpoint, from a billing standpoint, but also just the operational infrastructure that has to go in to manage some of this.
How are you seeing pharmacy operations step up and really start to fill some of those gaps you just mentioned?
That's a great question. Pharmacy sees the need to create an infrastructure to really help navigate this. They're at the table from when it comes down to P&T and formulary standpoints. They're at the table from the supply chain. So they really have a huge pivotal role in helping mitigate some of this. It is that communication that needs to be connected and really trying to bring teams together from a centralized standpoint to say, I've got drug Y. This is our preferred product. let's figure out now how all of these patients can align with drug Y, and then really trying to operationalize it. Pharmacy teams are great at operationalizing some of these processes. They just need to understand the impact from the billing standpoint and really helping connect all of those operational pieces together. So the teams where we bring pharmacy to the table here, they can really help connect that supply chain. They can help control things from a formulary standpoint, trying to create to what you can to the best of your ability, sometime with standardization, which is very difficult in this landscape, especially with drug shortages, all of the payer requirements based off that, but really trying to help eliminate some of that and really putting the pharmacist at the end of the line to say, revalidating, did the authorization get to the same as the drug that I'm being dispensing? And so everyone's needing to have a little bit more knowledge today around that billing code than they did in the past.
Thank you. Let's skip to the back end of the process with denials. This is obviously a multifactorial issue. So how do you approach this challenge?
I can take that one, Jim. So denials are definitely one of the more complex and frustrating parts within the revenue cycle. It's an issue that a lot of organizations know exists, but really struggle at times kind of wrapping their arms around exactly what the level of risk or exposure or impact is for them individually. We try to flip it a little bit. It's certainly an area that can be frustrating and make you want to bang your head against the wall at sometimes, but it's also a really valuable source of insight if you know how to use data appropriately. I think the approach within our team is often twofold. First, we focus on recovering any denied revenue, making sure there's processes in place to identify, triage, and potentially overturn any medication denials, especially in those high dollar areas, your specialty services, your infusion service lines, et cetera. Typically, that means having a dedicated team that understands the complexity and the nuance of pharmacy billing. Looks a little bit different than perhaps what authorizing a surgery or procedure may look like. So you really need to have a team engaged with a background in what can be a fairly complex work and making sure they're positioned to act swiftly and nimbly when issues do arise. I think the second part is probably equally, if not more important, is prevention. We'll take that same denial data and help identify any root causes or trends, whether it's missing prior authorization, medical necessity issues, operational gaps, or documentation concerns. That really helps create an upstream strategy to reduce the likelihood of those denials occurring in the first place. When you get the right processes in place, some denials actually can be pretty easy to overturn. You're never going to get away from them altogether, but we want to make sure that we're able to position folks to be able to respond quickly. Those are your quick wins, the ones that can be turned over quickly. There's also going to be more complex situations. And like Maxie alluded to, it's really getting the right team at the table and making sure everyone understands the associated financial and compliance implications that may occur. And it's really about what's turning what historically I think a lot of groups look at as a more reactive process for a lot of systems into a more proactive one, using data and insights to drive better performance across the pharmacy revenue cycle as a whole.
Tim, I think just to add on to that a little bit, and maybe emphasize really, because you've touched on the data aspect of it, but the data is challenging. There is no standardization across payers and how they are returning information to a health system. And then the health system, the EMR really has to be able to mine that data and maybe ingest it in a way that's consistent and puts it into a language where we can read it. It's hard to mine. And so the most effective teams that can really process that data will be the most successful, trying to understand what that data is telling you in terms of what the drug is, what's the reason, and then also aligning it with reasons and operational root causes within the organization. So you can have really a clean data that paints a picture for you rather than a bunch of gobbledygook that doesn't really help anybody. And it's hard to really operationalize that information. So the teams that have great report writers and able to understand that data is really key in this area.
Absolutely. It allows you to start eating the elephant one bite at a time that is in everybody's backyard or everybody's room, right?
Definitely. You touched on an issue that's been gaining momentum and it's getting more attention from the current administration, and that's site neutral payments. What's your strategy advice here?
Yeah, so site neutral payment is certainly picking up steam right now, right? The idea is to standardize reimbursement for services regardless of where they're delivered, whether that be a hospital outpatient department, a physician's office, ambulatory surgical center, etc. I think the overall intent is to help reduce unnecessary spending, discourage any like steering of patients solely due to differentials in payment or reimbursement. From a strategy standpoint, health systems really need to get proactive right now. First, understand what the overall level of exposure to these site neutral recommendations or proposals look like. What services are currently reimbursed at different sites of care? What is the associated reimbursement? And be able to model what a shift to a site neutral payment may mean for the organization financially. I think a lot of folks may be surprised to know CMS has already began implementing some of this site neutral payment restriction, especially for like off-campus outpatient departments. So it's no longer a theoretical anymore. It's really about operational readiness, tightening up your operations, your pharmacy workflows, charge capture, clinical documentation. So you're not relying on higher reimbursement to cloak any sort of current efficiencies that may exist within the system today. I think it also, Jim, requires a evaluation of the care delivery models that may exist within an organization. Can some services be shifted to lower cost settings without compromising patient care quality or safety? Exploring those different ways to keep patients within your system does require folks to get a little bit creative. Things like ambulatory infusion suites or leveraging your internal specialty pharmacy can really help position groups for success. I think pharmacy in particular is always at the kind of forefront of these high cost, high risk discussions. So understanding how any site neutrality future state would intersect with 340B eligibility, infusion services, and overall reimbursement and financial bottom line for an organization is really crucial. Site neutrality is not going to go away. It's probably going to change 3, 4, 5 more times, just like it has over the past 10 plus years. But the systems that are preparing now are certainly in a stronger position to adapt and thrive as this landscape sort of continues to shift.
Yeah, I think many organizations still see this as a regional phenomenon, but I'm with you. I believe that if it's not in your area yet, it will be shortly.
That's just it. It's just like biosimilar adoption or any of those other pieces, right? Where there are certain pockets of the country that were maybe impacted sooner versus later, but eventually it was a more sweeping change. I feel like this will be the same direction.
Yeah, let's talk about biosimilar adoption. I think that's another evolving strategy, certainly for organizations. What are you guys seeing here with formulary modeling and payer challenges around biosimilar adoption?
Yeah, I think biosimilars is a fun one to have followed over the last decade, actually. So if you can think back, the first biosimilar that hit the market 10 years ago, it all started with the changes in the billing codes. All billing codes were just the same. And then they transitioned to now each biosimilar having a unique billing code. Guess what that does? That created a chain reaction across the payers, across the manufacturers. And no longer was it a game of the cost competition. Now you have a competition about payer rebates. You have better margin. And now that created a whole host of downstream effects from there. We've continued to see more biosimilar policy changes that have really impacted this landscape to more recently when they all became pass-through status. And then you had the 340B reduction payment that impacted everything but the ones that had pass-through status. So the changes in preferred biosimilars for organizations have just been making 360 turns. One day you're going to be using brand X, and then the next day you're going to be moving it to brand Y. A lot of the policy changes has since changed with the Inflation Reduction Act, but it's still the same. It's just now more complicated to put an analysis together, and it's harder to make changes. So you really have to consider the cost to make a change and switch your products. Standardization is all over the board. I think this has really disrupted the supply chain and trying to really create a standardized supply chain from a cost standpoint, because the margin analysis can't just take in the simple Medicare rates anymore. You really need to take in your top 3 to 5 payers. The payers really change what the preferred biosimilar should and could be. And then if it's going to change, you got to keep updating these models. You got to update them routinely, at least on a quarterly basis. But you also need to factor in what is the cost to make that change. Because you make a change, now you need to think back through the entire supply chain. You need to think back on the prior authorization folks. Are they getting the authorization on the right product? Are you changing new patients? Are you switching historical patients? And how does that translate through the entire process so you don't make a change to improve some margin on one hand, but then end up in a lot of denials on the left hand? So the biosimilar landscape being changed as much as it has makes this an area of great opportunity. This is an untapped opportunity still. There's a lot out here. It's just you have to be nimble as a pharmacy team. You have to be willing to accept the change and really apply some of that cost to change before you start making some of these massive change. We have over 75 biosimilars on market now, and it's a growing pipeline. Payer mandates aren't going away. Site of care issues are not going away. So it just really complicates this margin analysis, but the opportunity is still there and it's still on the table.
Something you just touched on, charge structures and pricing algorithms. I think those are still often a problem for pharmacy. And over time, many organizations have created really complex and difficult to model charge structures. And I think they're hesitant to try and revise those structures, really for fear of breaking something and making it worse. Can you speak to a little bit more to this challenge?
I can take that, Jim. So definitely a challenge that we're seeing across a lot of systems right now, especially given the current healthcare landscape with a lot of recent mergers and acquisitions. We have organizations trying to sort of blend or merge their charge structure or move into a single electronic health record that requires some decision making. I think over time, organizations have ended up in some of those situations you just described, on a complicated and inconsistent charging for pharmacy services. I think these were usually built incrementally over time and with really good intention, but have become really challenging to model, difficult to explain to your patients or your payers. And you hit the nail on the head, Jim, really hard to revise without that fear of sort of unintended consequences. What's going to break if we make a change, or how would we know where our risks areas are? Working with several groups right now that are trying to simplify their approach. And it's really that balance between kind of a couple of areas, right? Medication billing compliance, transparency, sustainability for the organization, and patient affordability. It's really not just looking at your charge master anymore, but it's understanding how those charges may translate into reimbursement and how they're going to impact your patients. Want to make sure that if there's a certain fee schedule out there for one of your major payers, are you charging at least to what that fee schedule reimbursement rate would look like? A lot of folks aren't able to answer that question quickly, and that's where a lot of times we'll kick off a lot of these discussions when we work to do what's a really substantial change for an organization. I think one of the big issues is when you have an outdated and kind of overly complex pricing model, it tends to result in some variability in what patients are charged for the same exact service, depending on where they receive it, how it was prepared, etc. And from our standpoint, that can undermine sort of the trust the patient has within the system and makes it really difficult to meet some of the new pricing transparency requirements that exist within the country. I think Maxie highlighted it, and I think it's come up probably in every question you've asked so far, but it's really that collaboration being a critical component, making sure you have pharmacy, your revenue cycle teams, managed care, contracting, compliance, all at the table. When those groups all come together, you can help develop and build a charge structure that's not only defensible and compliant with all the regulations, but it's also a lot easier to maintain and can support sort of the long-term financial and clinical goals of an organization. Certainly a big change and a big adjustment, but it's sort of untangling or unwinding the web that kind of grows over time within a lot of different groups.
An issue that still surfaces is buy and bill versus white bagging or brown bagging. What are you observing here?
Yeah, I can take this one, Jim. I mean, this is still at the table. Organizations are dealing with it. I think organizations are a little bit able to deal with this. Brown bagging, I don't see as much anymore, which is a good thing. I mean, me as a patient and even a mom to a patient, I can't even remember if I need to store the amoxicillin in the fridge or keep it on the counter. Thankfully, the brown bagging is not something that we see quite so often. And it's one of the easier ones to say to organization, I think there's brown bagging, you probably should change that practice. And they get it. They're like, oh yeah, that is not appropriate. We don't need to do that. So the supply chain is being maintained within the pharmacies or, the health systems. White bagging is still a concern. White bagging, the site of care policies have not gone away, and they are increasingly becoming more restrictive. So if organizations haven't really built a multitude of alternative sites of care, and that being one of the biggest strategies today is like, where can I deliver these patients so I can kind of maintain with this revenue internally? The specialty pharmacies is a great avenue there. If you have a specialty pharmacy that can kind of help make this transition of white bagging to a clear bagging scenario, that's great. Not always possible in the policy structures today. And so you really need to have that avenue or outlet for an alternative site of care, whether that be an ambulatory infusion suite or home infusion, really to be able to maximize and keep your patients within your health system. White bagging has become a mainstay. So your folks within clinics, your folks, doing prioritization, it goes back to that front end piece. They're good. They know what to do, and they say, "Yep, we'll just go to CVS." Really, they've taken that easy button to say it needs to go to CVS, and we'll get it, and we'll be able to service you. It's really trying to take a more critical look at this to say, the white bagging volume that I have in the system today, is that a healthy amount, or should I transition that to really think through an alternative site of care? And if I don't have a white bagging concern, where are my patients going? Are they leaking out of the system? Likely that's the case. So the knowledge of understanding of where these patients are going based off of their payer is very important. And so one of the biggest strategies here is really having a health system own and create some of these alternative sites of care. And that's going to be the one thing that I think Tim mentioned in a previous question, is that alternative site of care is going to help drive success for organizations, really given a place for patients to go and patients to receive their drug, and an organization to be financially healthy on these drugs and these administrations.
As drug costs continue to escalate, I think so are payer audits to ensure proper billing and payment for those drugs. Some common audit flags might include overbilling or billing without documented infusion or unbundled services. So how can pharmacy work to best support the generation of clean claims and successful audit performance?
It's a great question and a really important topic today, Jim. Especially drug costs continue to climb. Payers are becoming more and more aggressive with auditing to ensure kind of transparency on both sides. Definitely seeing all the flags you just mentioned. These are issues that certainly can lead to significant revenue swings within an organization, dollars that have been booked in your general ledger that now there's a knock on the door asking for payment back. And organizations need to be able to respond quickly and defensively related to those requests when they come. I think at its core, it's really, again, that strong partnership between your pharmacy and revenue cycle teams, bringing all those different perspectives forward, your clinical teams, your operational teams, your financial teams, to make sure you're equipped to identify where these breakdowns are happening and then how to swiftly address them and prevent them in the future and help close that gap. There are tools and analytics functionality that can help flag some of those high risk situations before they even become problems, before a claim even gets submitted to a payer. So identifying, let's say, if a medication was billed incorrectly, or if drug waste wasn't documented properly, or it's missing a required compliance or regulatory modifier. Those are all important roles that a pharmacy team can help build and grow and become experts in. There's not really always a perfect blueprint on how to navigate all those pieces. So it really requires intent and effort to sort of fertilize that skill set within your pharmacy system. But honestly, the pharmacy team's often the ones closest to the workflows, closest to drug changes, inventory and supply chain, et cetera. So having those folks with a seat at the table, I think really positions you for success. On top of just those tools, though, it's really building a culture where everybody understands the value of getting it right the first time. You talked about clean claim rates. So how often are you able to submit a claim, move it forward, and not have it bounce back from a payer or hit a third-party billing scrubber? How often are you doing it right the first time? And a lot of times that includes, again, making sure your charge capture functionality and workflows is aligning with all the documentation in place, having some level of internal audit to catch any issues early and before they develop into a larger issue. Really at the root of this, it's a lot of staff education to make sure folks know what to look for and how they can help. We don't want, the left hand of the pharmacy to be doing one workflow, the right hand of maybe a denials or a follow-up team to be doing something else, and having those two groups never talk. A lot of times that's where we see inefficiencies and groups that are struggling with clean claim rates because they're going back and forth, and it's maybe a simple operational change that would solve all the problems for this other team. But if you never come together and talk through what those different areas are seeing and where their challenges are, it's really difficult to be successful moving forward. I think that education, in addition to really clear operational processes and procedures around, again, drug waste, modifiers, bundled services, et cetera, I think is really critical. When pharmacy is actively engaged in these conversations and not just reacting or responding to denials, but really helping shape the process, that's when you see real improvement and sustainable improvement, not just in compliance, but financial performance for a pharmacy group as well.
Well, from our discussion so far, it certainly points toward pharmacy revenue cycle being a team sport. How do you approach the formal structure and integration of pharmacy revenue cycle?
It's a great question, and I don't know if formality is the right way to put it, but it's definitely one of the most enjoyable parts about my job today. Right? We work with organizations that do not even understand the titles or the people within the organizations that may be impacting something. And so it's really starting with having a conversation, bringing people to the table. And when I say bring it to the table, we have to sometimes start out as, I want to know who does X in an organization. And most of the time we hear, well, we've never heard of that and we don't know that person. Someone knows that person in the organization. So we're really trying to play a who's who or name game within an organization first to really get people at the table. And then we create just a working project committee, right? We're trying to solve one problem and we need all of these stakeholders at the table. And so we put them all on the same call in the same room and have a conversation. And you can see like light bulbs starting to light up. And we're like, wow, we had no idea you did that. We didn't know that what we were doing impacted you so much. And that's when the connections start happening. And that becomes a lasting connection. And that then grows into what you could call a formal structure and a formal committee. But most of the time, it's all the informal connections that are happening up front that really can start driving that change. And then once you create those wins, then you can formalize a structure so you can have that proactive review on things, that proactive look, that proactive assessment of a process before you implement a process. That's when you become and have that real accountability within a team. But it's really just connecting the people and trying to speak both language and translate that language so all teams can understand what people are trying to say.
Maxie, one of the things I did after I attended your workshop was I called the director of RevCycle and made an appointment just to go spend 2 days at RevCycle and just observe what the people did. And it was really eye-opening. I could think of lots of different things that we could do in the pharmacy department on the front end to make their job better and more efficient on the back end, just by observing what they were doing.
Yeah, exactly. And I know I can think of it. One of our clients, it was a new pharmacy leader that had just joined the organization. And he was there to learn. He was brand new. He didn't even know who pharmacy was, more or less who revenue cycle were. But he was overseeing a few of the process that touched revenue cycle. And we were there at the table to help him connect him to the right people. And we're like, why don't you go have a meet and greet with this person? Just spend half an hour with them talking about what they do and seek to understand first. And then you can kind of help back into some of your problems and really have and work and make some change.
Another challenge, and Tim, you touched on this briefly, is performance metrics. I think too often pharmacies really working off their monthly operating statement, which doesn't really reflect the reality of what's actually being collected. What do you guys like to see people looking at to effectively evaluate pharmacy revenue cycle performance?
It's a great question, Jim. It reminds me of a message I got really early in my career from a mentor. Those monthly operating statements is your rear view mirror, is the way it was described to me. Tells you where you were, but doesn't tell you where you're going or what's happening right in front of you. I think really what organizations need to focus on is more real-time actionable metrics that reflect live current performance, all the way from patient comes in, receives a medication and an associated charge, all the way through that collection cycle. So what should folks be looking at? Couple things come to mind. One is your charges versus collection, right? That's kind of the easy starting point. Are you actually collecting what you're billing out to patients, and does it cover the cost and expense of the medication and the services provided? And then we try to get a little bit more granular. How does that vary by service line or by specific payer or by specific drug? Where are those key areas where organizations may be performing better versus worse, and how do we focus in on those areas where there is opportunity on the table? I think the other one that comes to mind is what we call your charge lag, or your days to payment. How quickly from the time a medication charge drops within your medical record are you actually receiving payment? How quickly is your team working? How efficiently are they able to move? And how quick are your payers responding? If you have really long delays in that space, that means cash flow is kind of stuck in a limbo spot, right? So an important metric to track, and again, doing that by payer, by service line, et cetera, really gives a little bit more insight into overall performance. I know we touched on denials and some of the pre-access and prior authorization work as well. I think if an organization is experiencing high denial rates or low first-time PA approvals, certainly a red flag and an opportunity for process improvement that I really think pharmacy departments can really help to remedy, because they're right stuck in the middle of that workflow and have a really good track record of improving operational efficiencies within a system. We talked a little bit about audits as well. I think both internal and external audit success rate is an important measuring stick, kind of a pulse check of what your overall compliance looks like. Are your claims clean, like we talked about before? Are they defensible? Is the system working as designed? Everybody might think that medication waste modifiers just happen somewhere in the ether. Is it really working that way? Or are we seeing feedback from payers or from internal audit that shows maybe a different situation is occurring, especially for some of those unique workflows, your anesthesia gases or your ORs, or some areas that follow a little bit different medication use processes. Operational efficiency is probably another one. Things like how often are you having to white bag or clear bag medications? What does the time to scheduling look like for infusion? How quickly are you able to secure those authorizations and get patients that need care in a chair and treated in a timely manner? On top of that, knowing that there's more prior authorization and pre-access sort of expectations and requirements being put on organizations, how often do you have to rework claims? How often do you have to touch them multiple times? Every one of those inefficiencies is a cost in an area where a lot of folks can't afford or don't have the resources to, touch a claim 3 or 4 times before it ultimately goes out the door. I think the bottom line is, if you really want to understand and improve pharmacy financial health, you got to go beyond some of those static reports like your operating statement. Build dashboards, track some trends, drill down to payers and drugs, and that's how you turn that data into decisions and real performance improvement.
Well, great information today, certainly highlighting the importance of a robust approach to pharmacy revenue cycle. Any final thoughts before we close?
Jim, I would just say it takes a village. Support can come in a variety of ways. Going alone is possible, but growing together as a team internally or through national organizations or vendor support can really achieve stronger results faster. I appreciate your time today. Thanks, Jim.
Couldn't have said it better, Maxie. Thanks, guys.
And Maxie and Tim, thank you very much for your time and insights today. And thanks everyone for listening.